Hi there, my name is Vic V. I'm an ENT consultant surgeon working for the NHS in central London. And in this video, what I'm going to do is explain to you what happens once you've been told that your child needs a tonsillectomy or tonsils and adenoids done. Now, there's lots of reasons why you'd need your tonsils and adenoids taken out. And briefly, it could be lots of infections. It could be glue ear, particularly for adenoids. It could be a blocked nose, blocked throat. And typically you see that with snoring, sleep apnea, trouble breathing at night. But I'm not going to go into all of that. You've got to the point where you have been told that your child needs a tonsil or adenoid operation or both together. And what actually happens now? So you would have just seen the consultant, someone like me or one of the junior doctors, and now you're just told to just go home. And it feels a bit weird. And on the NHS, there is quite a long waiting list. You can, because it's quite a long waiting list, you say, well, how long is the waiting list? 6 months. Well, can we make it 7 months? Because then it'll be in the school holidays. And typically there is a little bit of slack in the system. That means that you can try and book your child's tonsils and adenoids in the school holiday, so they're not missing too much school because they need approximately 2 weeks off after these operations. So it is worth sort of trying to ask, is there a possibility we could do this in the summer holidays or in the Christmas holidays? Obviously, you want to do it at the start of the Christmas holidays so they get to eat Christmas dinner and things like that. But have a think about that as well. When you get time and you're getting close to the point where your child's coming in for their operation, you need to make sure that that your child is healthy enough for it. So they may have a cough or a cold, they may even have tonsillitis. And in that situation, unfortunately, you're not going to be able to have the operation. If you've got tonsillitis, that means an infection of the tonsils, or you've got a cold or a cough or something like that, particularly a cough. We worry about doing an operation in these situations. So it's not something that I would basically call up the hospital and say, actually, my son's got or my daughter's got a cough. What should I do? And they sometimes bring you in and check you over. But generally, if you've got a cough or a cold or tonsillitis, the operation will need to be postponed. Now, there are some times when your child is getting tonsillitis or adenoiditis or these problems all the time, and you're having this operation just to try and get rid of these infections. And we will postpone a couple of times, but they've come to the point where we go, look, we can't get a window of opportunity that we can get this child in for their operation because they keep getting infections. Every time they come in, they seem to get another infection. It's probably chronic tonsillitis with sort of acute episodes on top. And they're pretty much always infected. And no matter how many antibiotics we throw at these children, they still got infections. In that situation, there will come a time when you and your surgeon will go, look, I know the risks are greater. The risk of bleeding and having being miserable afterwards is greater, but there's no way around this situation. We're just going round and round in circles, postponing this operation over and over again. So have that conversation with your doctor in that first appointment and say to them, look, my daughter gets infections every month. And you're saying don't have an infection, within the first 6 weeks of this operation. That's just not going to happen. They get it every month. They need antibiotics, or they should be getting antibiotics every month. But the GP has said no more antibiotics. It's just not worth it. It's not worth it anymore. It's not working for them. So have that conversation on that first clinical appointment. Like, how many times do we postpone before we just say, let's just get on with it and accept the risks? And yeah, and everyone's slightly different in that context. Some surgeons are very, very scared of this. Some surgeons will be a little bit more pragmatic and say, let's wait until the operation's been cancelled 2 or 3 times before we say enough's enough, let's just get on with it. So talk to your surgeon about that. So when you get close to the day of the operation, typically sort of a month before, 2 weeks before, you may be invited to a pre-assessment clinic. And that basically means that you'll be coming into hospital and talking to a nurse or an anaesthetist and speaking to them about the health of your child. Not so much about the tonsil operation itself, but it's more about, do they have asthma? Do they have any allergies? Are there any other things that may make the operation more difficult? And there are situations where, for example, people with obstructive sleep apnea, children with obstructive sleep apnea, they may have problems causing, these infections or these obstructions are resulting in like a sickle cell crisis, or they've got other problems that mean that they have like an unusual facial shape, or dysmorphic features, which makes the anesthetic more difficult. To get the tube in the throat makes it far more difficult. And there are lots of things to talk about in this. It's not really about the tonsils and the adenoids itself. It's the rest of your child and making sure that your child is safe throughout this operation. So it's, collecting data. And so it's typically a tick box thing. Does he have asthma? Does she have diarrhea? Or are there any other medical conditions? What medications are they on? So try and turn up with, your little red book, if you've got that in the UK, or a list of medications. If you could write down all the past medical things that have happened to your child, have they had their vaccinations, all those sorts of things. And it's useful because it speeds up that process and you can get the information relayed very quickly. And do turn up, because sometimes if a lot of this stuff is found on the day of the operation, the anaesthetist will go, ah, we haven't got all of this sorted out yet. We're going to have to cancel this operation. You have to go back to pre-assessment, get all these things sorted out, and then come for your operation. And that delays everything. And you're all psyched up for this operation. You want to come in, get it all sorted out, and then to be told at the last hurdle, no, you have to go through this whole process again. It may take you a couple of months. So try and be prepared if you possibly can. Now, in the next sort of week or so before the operation, it is worth talking to your son or daughter about the operation, because it is quite scary to be brought into a hospital, and they'll know that you're nervous. No matter how much of a brave face you put on, that children are amazing at picking up anxiety in their own parents. They're very, very clued in. That's pretty much the only adult they really know, and they observe everything about you. So they will know if you're nervous. So talk to them. Feel free to talk to them and explain the situation. There are loads of little videos, I guess, on YouTube and other things that will explain what's happening and say, look, here's a picture of you, here's a video of you snoring at night, and we're worried this is causing you problems. We just want to make sure you don't snore anymore, or all these infections that you're getting, we're trying to remove those infections. Look, it's not going to be very nice, because you're going to be on some painkillers. It'd be like having a cold or a flu or a sore throat, but afterwards you won't have any of these problems anymore. Talk to your son or daughter how you think it would be best to talk to them, and explain what's going to happen, which is kind of what I'm doing here as well. So explain the process and what's going to happen, and then you get to come home. You're off school for 2 weeks, and you get to eat loads of nice food, and do what you think is best for your son or daughter, but explain the situation. Don't just bring them into hospital and says, "Oh, we're going to get this done. Don't be such a baby." It helps them feel like they've got a little bit of control of their environment. It's not so scared, because there are times, when you're coming into a strange operating theatre and things like that, it must be scary for children. It's scary for adults. So try and alleviate that fear, because we don't want the blood pressure to go up, the heart rate to go up, and all those other things. So try and keep everything calm, and preparing your child for an operation is really important. Um, Try, if you can, slightly influence when your child is going to eat. If you know that your child's operation is 7 o'clock in the morning, say, or they'll come in at 7 o'clock in the morning, and they'll have their operation between sort of 8, 9, sometimes 10 o'clock. Try and think to yourself, well, he has a big breakfast at say 6 o'clock in the morning. We're going to have to feed him quite late at night so he doesn't feel so hungry in the morning, because you're not allowed to eat for roughly 6 hours prior to your operation. Now, some trusts say different things, but on average, if you haven't been told, just assume it's going to be no food for 6 hours prior to the operation. You may be allowed water, and some trusts are different about this as well. You may be allowed water up to 2 hours prior to your operation. And sometimes they say clear fluids, which doesn't make any sense. I've seen people who've been told, oh, yes, you can have clear fluids up to 2 hours before your operation. And they come in completely drunk because they've had vodka. And, they clearly don't want the operation. But like a barley juice. Some anaesthetists will accept and some anaesthetists won't. So it might be just simpler just to say you're only allowed water. And we're talking sips of water, not gulping water down. We don't want a full stomach with food or water before the operation. And so bringing these children in early in the morning, and if they're used to having breakfast at 6 in the morning, you might have to change their meal times on the run up to their operation. And what that does is it helps them. They don't come in completely starving and slightly hysterical because they're really, really hungry. They can't even have water. Their mouth is dry. So just be a little bit careful about that. Try and change their breakfast to a little bit later so they can get used to that. Give them a big meal the night before and maybe quite late at night. So they sort of sleep through and they wake up and they're not so tired and stuff like that. And when they come in, they don't feel so hungry and sort of hysterical in the morning. The other thing to think about is when you're come in quite early because a lot of NHS hospitals, particularly in London, you struggle with parking, you struggle with public transport, you struggle with all sorts of things. It may be worth when you come in to get some food that they will like. Get them some drinks they like. Get them something to entertain them because there'll be a lot of waiting around, particularly on the NHS. You'll be, give them, if they like colouring in, give them loads of colouring pencils and things like that so they can occupy their minds while people are wandering around all these bays talking to the parents and saying, please sign this. And oh, does he have any allergies? All that sort of stuff. You want the child to be distracted and so everything can calm down in their mind. So try not to have, try not to rely on an iPad or something like that because sometimes in a hospital the connection is terrible. And then you've got nothing apart from a calculator to play with or something like that. So maybe books, little games that you can play. You can bring all those things that you can play on the bed while you're waiting for your operation. Um, when you do eventually come in, make sure they haven't eaten, give them something to do. They can play around and all that sort of stuff. They will typically see a nurse when they come into the ward. Make sure you know where the ward is as well. So sometimes being really well prepared for this. Go to the ward or the day surgery unit typically, and the nurses there will introduce themselves and they'll talk to you. Check the child's height and weight. That's really important because that determines how much anesthetic we give to children. We check again, and you'll find this a lot. We'll check millions of times what the allergies are, what other medical problems there are. They'll check how much he can or she can open up their mouth. And there's all sorts of things that you'll be checking over and over again. It'll seem like such a bore. Try not to get stressed by it. It's just we want to pick up little things and we want to be absolutely sure we got the right person. So we'll check the name, we'll check the date of birth, check the wristband on his or her wrist or on their ankle or something like that. So all of these things will be done over and over again. At one point, they'll get your child into a little gown. Normally, they're allowed to wear their underpants, but there's a gown that goes over like this. And you tend to put your arms in this way rather than it being like a cloak or a jacket. And that's basically so when you're lying down, there isn't a knot on your back. You want the back to be completely free of fabric because when you're lying like this for an hour or so, it can press like a knot of fabric. It can press on your back and cause a little sore on your back. So we're trying to avoid that by having just a bit of cloak on the front of your chest, so you're sort of covered up, and you know you can't have all the clothes that you normally can. It just needs to be opened up at the back. So when you're lying on the operating table, it doesn't press on you. They will put some magic cream, the local anesthetic cream on the back of your hand, sometimes also in this area here, inside the elbow. And the idea behind that is that if it stays on there for roughly 40 minutes, 45 minutes, it numbs the area. So when they do eventually put the needle in, that is not so painful, doesn't hurt quite so much. It does hurt a little bit, but it's something you should let your child know about, that this is what's going to happen. It means they can give you lots of nice drugs so that you can sleep nicely and not worry about it. You can say, as I said, say it the way you think would be best that your child would understand. So there will be a little bit of that. Sometimes the anaesthetist will ask for other things as well. They'll ask for other tests, sometimes an X-ray if you had a cough or something like that, or they might look in your mouth. So the anaesthetist will walk round and see you and ask some questions, ask any other problems. It may be exactly the same as what the pre-assessment said, but they're just checking off, make sure that no one's missed anything on the pre-assessment. And then typically, roughly at the same time, the surgeon will come round as well, either the junior doctor or the consultant, and they will talk to you about the operation as well. Not often talking to the child itself, but sort of saying, look, these are the risks. And we go through all this again. These are the risks. These are the complications. These are the things you should do. And are you okay with that? Any questions? And then they get you to sign typically a big sort of like an A3 piece of paper with the surgeon's name and the parent's name. So you write your name, date of the date that day, your surname in capitals, and the word mother or father in the corner. If, however, you're not the mother and father, but you have parental responsibility, you have sort of responsibility for the child, you need to bring that evidence in. You can't just say, oh, yeah, I'm the foster carer or something like that. Most foster parents know all this, but you can't just send in the grandparents in to look after the kid. You need someone with parental responsibility for that child. So uh, think about that before you turn up. You need to be a parent or someone with responsibility for that child to sign that document. Then what will happen is there'll be a bit of a wait, as there always is, because what we tend to do, the surgeons, the anaesthetists, and the nurses all get together in the start of the list, and we talk about each child and say, this child's got this problem. He's allergic to penicillin. This person's got other problems with their metabolism. Maybe they should go first. So the order can change. You may be thought you're the first because, oh, my son is the youngest out of all of these children, therefore he's going to go first. Sometimes that's not true. Sometimes the child with diabetes, even though they're 9, 10, 11, may be going first because they can't not eat for that long. Or the child with a sickle cell crisis, sickle cell problems may go first. All these other things may change the order of the list. So don't walk in thinking we're definitely going to get done at 9:34. It's just not going to happen that way. So be prepared that there may be delays, there may be changes in order. They may say, actually, no, yes, he brushed his teeth, which is fine, but he didn't take his tablets this morning, or he didn't take this or that or the other. So actually, he'll need to wait 3 or 4 hours before he can have his operation. Or he drank a little bit of milk. You have to cancel the operation. So remember that. Don't eat or drink. Only have water, maybe up to 2 hours before, but ask your pre-assessment nurse beforehand what the rules are in your hospital. Eventually, it'll be your time to come in and have your operation. So you you choose typically which parent is going to go with the child. So have that ready beforehand and say to your child, look, mummy's going to go with you into the operating theatre. So you're going to be safe the whole way. We're going to look after you the whole time. So one of the parents goes with the child, with the nurse, sometimes wheeled on a bed, sometimes they walk to the operating theatre. And there are typically two parts to an operating theatre. Actually, sometimes they go to a holding bay, it's called, a bit like, when the gates before you get on your flight, there's a gating area where you all sit and wait for a bit. There's a bit of that where they check again, are you the right patient? Are you the parent? And have you signed the forms and all those sorts of things. From the holding bay, it's typically half an hour max in that area, in the theatre complex area. So not on the paediatric ward anymore. You've now gone to the sort of holding area. And from there, you go to the operating theatre area. Now, there are two parts to that. One is the anaesthetic room, which is typically a little bit smaller, roughly the same size as this room, maybe a bit smaller. And there's a table in the middle, and there's an anaesthetic machine there. Sometimes you go straight into the operating theatre, which, everyone's slightly different. Each trust is slightly different, but you'll be going into a room. The parent is allowed in at the same time. And there'll typically be a couple of nurses, a surgeon sort of milling around in the background, the anaesthetist, and possibly a junior anaesthetist with them learning. And then there's someone called an ODP, who's a nurse that helps the anaesthetist with the whole anaesthetic process. And they'll be doing the checks all over again. Every time you move a room, you'll go through all the checks again. And you'll be there with the parent will be there with a little hat on, little things over their shoes to keep the area relatively sterile. You don't have to be dressed up. You can typically wear clothes like this, but you'll be covered up so you're not spreading germs around everywhere. Um, at that point in the anaesthetic room, they typically put the needle in the hand. So they take the little sticky tape off with the cream underneath, give the area clean, and then put the needle in. Um, it's often best just to distract the child. They put the arm like this, and you look at the child and just talk to them about, football or riding horses or whatever they're into, um, and just talk to them and distract them. And it's a bit of pressure, particularly if it's not been put on for long enough. It can hurt a little bit, but just keeping nice and gentle, keeping everyone that you look secure, everything's fine, don't worry. Once the needle goes in, it becomes so much easier. Sometimes it's just not possible. Putting the needle in is very difficult in very young children, particularly for anaesthetists. And so they may go, particularly if the child is sort of thrashing around a little bit, they may go, look, we're going to use gas to make them fall asleep rather than using a needle. It can be a little bit difficult to watch because what you're doing is putting a mask on a child's face and just holding them. And it's not very nice to see because they're sort of struggling, but it's almost a good thing that they struggle because they cry and they take this huge breath in, which sucks in loads of the anaesthetic, so they fall asleep very quickly. It's typically, I'm not an anaesthetist, but typically most anaesthetists will say it's often better with the needle because they can just squirt the stuff in within 30 seconds, the child's asleep, and there's no real stress. There's certainly less stressful for you as the parent and for the child. So in the anaesthetists I know, will typically go for a needle in the hand. Sometimes, if the child has other medical problems, particularly lung problems, or if they're quite a big child in terms of being overweight, they may put some oxygen on the face prior to putting the needle in the back of the hand. And what that does is it fills the lungs up with as much oxygen as possible, sort of removes the nitrogen and replaces it with loads of oxygen, because it gives us a bigger window of opportunity to get the tube into the throat. But in any case, what will happen is at that point, once the needle's in and the little sort of white injection, so it looks like milk going into the back of the hand, it's called propofol. Once that goes in, within 30 seconds, the child just falls straight asleep and there'll be a mask on their face. And then one of the nurses will go, your child's asleep now. Let's take you back to the ward. And you'll go back to the ward and the anaesthetist will get the tube in the throat and the surgeon will do the tonsils, the adenoids, all both together. The whole process, so you've gone back to the ward now and you're just waiting rather impatiently. Everyone, I'm a parent, I've got two boys. It's quite scary to walk away and just put your trust in a system, in an anaesthetist looking after your child, making sure the tube's in the right place, and a surgeon to do their operation properly. But it's really hard, and it's understandable to be stressed and whatever. So go back, find something that will distract you for that time, because it will be at least an hour or so before they will call you back to see your child. So the idea is that they will be looking at you when they fall asleep, and because the needle's going in their hand or the mask, and they'll be looking at you so that they feel slightly secure with that. And then they'll have the operation. You'll be back on the ward by now. And then you'll go back to what's called the recovery bay. So once the operation's over and they're safe enough to move from theatre to what's called the recovery bay, another area of the theatre complex, there'll be a nurse looking after them and they'll be slowly waking up from the operation. The tube will be out of their throat typically. And once they start waking up and they sort of vaguely know where they are, that's the point where they'll bring the parents back in. Actually, for the first hour or so, they probably won't remember much at all. But whilst you're away for an hour, the nurse will come back to pick you up, take you back to the recovery bay. You'll see your child sort of partly sleeping, maybe crying because they're sort of a little lost and don't know where they are. And there's a lot of sort of hugging and don't worry, everything's fine, all finished now, all that sort of stuff. And after a bit of feeling a bit miserable, they'll probably fall asleep. And typically it's about 2 hours they sleep for. Um, and in that time, as long as the nurse, the recovery nurse looking after your child, is saying, he seems fine, he's just breathing normally, there's no sign of any issues. Let's take him back to the ward, the place where you first started. And you go back to there and you just stay with your child. They'll probably sleep for a couple of hours afterwards and they'll go, oh, no, 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 you'll be sitting there thinking, "Hope everything's all right." Now, there is a little bit of a worry that a child may bleed in the first sort of 6 hours or so, which is why you can't go home in the first 4 to 6 hours, typically after an operation, because there's a small increased chance of bleeding in the first few hours. So in that situation, if you can, try and get the child to sleep on their front a little bit. So if they are bleeding a little bit, it comes out of the mouth and you see it staining the pillow. Now, there's always a little bit of blood. Um, but if you start seeing the blood coming up, then you can tell a nurse immediately, and then we can get that sorted. The only minor problem sleeping on your back is that they may start swallowing the blood whilst they're sleeping. And everyone does that for a bit, and then suddenly wake up and they're vomiting blood everywhere. So just be slightly aware of that. If you're worried about your child bleeding or there's, they've got a bleeding problem or something like that, it may be worth sleeping them sort of on their front. There'll be some monitoring on their fingers and oxygen monitors and things like that. And they'll just sleep, as I said, for about 2 hours. And then they'll wake up and they'll be really hungry. That's very normal. They haven't eaten for now, almost 12 hours, maybe more, and they'll be really hungry. So just go slowly with the food. Don't let them gobble a huge McDonald's or something like that, because your stomach and all the drugs in your system, you may be feeling a little bit sick. So take a bit of time over it and maybe sip some water to begin with, maybe some juice, milkshake, and work your way up to yogurt. And within sort of half an hour, they can eat something properly. Once you know that they can keep it down, they're not going to vomit it all up again. And they might end up sleeping again for another hour or so because they've had some food and they'll fall asleep again. A lot of this time, when they're having their operation, it's only about 10 minutes or so for their actual operation, but they're asleep for a lot longer. We don't want them to, it's a general anesthetic, they don't want them to feel any of the operation at all. So they're asleep for about 15 minutes prior to the operation, and they're asleep again for another sort of 40 minutes after the operation. So um, there is an awful lot of anesthetic going into them, and we want them to be as comfortable as possible. And we don't want them to feel pain. Some of the drugs can make you feel a little bit sick, but at least it gets rid of the pain in the first few hours. So it makes it a little easier to help a child who's in pain, doesn't know really where they are, what's happened to me, why is it my throat hurting, all that sort of stuff. All of these drugs, hypnotic, something to stop you from remembering all of these things, the painkillers, the anesthetic itself, all of these drugs are given to help your child through that initial phase. So after a while, once your child has woken up and they've eaten something, it'll be a kind of boring. And so another reason to bring loads of books or little games to play, and you'll be kind of desperate to get out of there. But because of that risk of bleeding for the first 4 to 6 hours, depending on what your hospital has decided is the safe time to go home, you'll need to wait that time before you go home. And typically, the nurses want to see that the child has eaten and they haven't vomited everything up. They've walked around the bay, they haven't spat out any blood, and they've typically gone for a wee or something like that to make sure everything's sort of working. And when a child is at about sort of 4 to 6 hours and they're sort of desperate to go home, they're not drowsy anymore, they can play around and everything's fine. It'll be about that time the nurse will say, look, you can go home now. Because it's about 4 hours sometimes in some hospitals, you may not get to see your doctor afterwards, because we do so many of these tonsils and adenoid operations that sometimes children get to go home before we've even finished the whole operating day. If it's only half a day operating, your surgeon will probably be able to come around and see you at that point and say, look, everything was fine. The tonsils came out, the adenoids came out, or they're infected. That's why we're giving you antibiotics, all those sorts of things. But sometimes you get to go home without actually speaking to a surgeon. If you want to speak to the surgeon, just let the nurses know early on in advance, because they may come around in their lunch break or something like that to say, by the way, everything's fine, I've got to get back to the next operation, or something like that. Do take care. And the other weird thing, whilst I'm on the topic, is that with tonsils and adenoids, in the vast majority of people, because we're trying to keep our waiting list down, you may not see your surgeon ever again. It may be that's the last encounter you have with the hospital. We often tell patients, you've had your tonsils and adenoids out, you should be fine. It works on, the vast majority of children for, if you don't have tonsils anymore, you're not going to get tonsillitis anymore. If, there's over 90% success rate of taking tonsils and adenoids out for obstructive sleep apnea. So we don't tend to bring children back. Some units do. So you may find that, oh, I'm seeing my surgeon in 2-3 months' time. And I think in an ideal world, you would do that. You would bring people back. But in some hospitals, we just don't have the capacity. So you may find that happening. And you go home, and it can be a little bit stressful because you'll have all these medications to take, mainly painkillers and sprays and things for your throat. So just be prepared for that. Think to yourself that paracetamol is given every 6 hours. So take it every 6 hours, 6 o'clock in the morning, midday, 6 o'clock at night, wake them up at midnight, take the painkillers, because you don't want them to wake up after 12 hours sleep desperately in lots of pain and won't even swallow a tablet or syrup anymore. And then you're stuck in this situation where you're trying to claw back with painkillers to get rid of the pain. It's best to stay on top of it at all times. Ibuprofen is given every 8 hours, so you end up staggering the doses slightly. Try and aim for your painkillers, particularly the Nurofen, ibuprofen, to be about an hour or so before a meal time, because we really want you to eat proper food after an operation. There's lots of studies now. I don't know, somehow it seems like mostly American websites, but the research shows that you should eat normal food after a tonsillectomy, not sort of soft food, because what you're trying to do is scrape off all the dirt and stuff like that to allow the skin to heal over. If you see sort of white stuff at the back of the throat, the body has to get rid of that, make it go red, as it were, and let the skin grow over that area. And that's when the pain goes away. And even if you look at the Great Ormond Street website, they say eat normal food, don't just have soft food. Although instinctively as a parent you think, oh, I just don't want them to be in any pain at all, just have yogurt or something like that. Actually, no, just give them toast with butter on it and jam and whatever you need to do. Sometimes you bribe the kids and you go, look, you're not normally allowed McDonald's, but let's have McDonald's for 3 days straight or something like that. So just give them whatever they'll eat and make sure they do have good meals, because you want to give them enough energy to fight off an infection, or start the healing process really going, and try your best to feed them. Make sure you stick to a routine and say, here's your painkiller, in an hour's time you get to eat your food. You can sometimes get given a spray that numbs the back of the throat, so for the first bite you have of a meal, it's not so horribly painful, because kids, it's generally hard to feed kids at the best of times, but if it hurts at the same time, it's really hard. So sometimes using the spray, Difflam spray or some other type of spray, can numb the throat, so they're not so anxious about taking that first bite. And once they've got the taste of chicken nuggets or pizza or whatever you want to give them, whatever will satisfy your kid and make sure the kid will eat a meal, just do it. Just get them through these first few weeks. What we're trying to do is avoid an infection, if at all possible. It is hard because you're trying to feed a child and they're not eating, and you give them the painkillers and they're saying they're hurting, I don't want to eat anymore. Maybe nibbling food all day, even if it's peanuts or nuts or something that keeps the muscles at the back of the throat working. And the reason for that is that sometimes it's not the raw pain that you get from having the tonsils removed. It's actually the muscles going into cramp around it. And a bit like any cramp, like on your foot, you get a little cramp on your foot just near the inside of your sole. It's a muscle cramp. And no matter how much painkillers, morphine and things like that you give to someone, you don't get rid of that crampy pain. You actually have to stretch it out. Or, when you get a cramp, you see footballers on the pitch and they get a cramp in their calf or something like that. You have to actually stretch that muscle out and the cramp eventually goes. So that's what I'm saying. Little and often eating sometimes helps children so they don't feel so scared when they get to mealtime, because their throat's so tight and sore when that first bite is really, really painful. And so you'll see some children who not want to swallow at all. They sit there and they spit out their saliva and things like that. Don't let them do that. They refuse to talk because they don't want to move any of the muscles in their throat. Everything is going into cramp like this. As soon as you get them to speak, as soon as you get them to swallow, sip some water, anything like that, the muscles start working again, and you can start getting into that process of eating and being a bit more normal as much as possible. Um, Another way to avoid infections is, I'm afraid, not to go to school. And the idea is because schools are just full of infections. You know, if you remember when you sent your child to nursery the first time, the first 6 months they come back with every horrible flu under the sun. They're just never well, um, and so be aware that you'll need to probably avoid taking your son or daughter to school for the first 2 weeks. So take time off to be at home with them. It is quite hard because you have to try and entertain this child. You can't really go and play dates because you're trying to avoid infections from other children. But you can go out to the park, and that's fine. You can do things out in the open typically because it's less of a chance of getting an infection. If you're in an enclosed space inside someone's house, that's a little bit harder to avoid germs and things like that. But you're trying to avoid infection because getting a cold or a flu would be horrible with tonsillitis at the same time. Taking antibiotics and things like that, and having a snotty nose and a sore throat, it's just too much for some children. Um, so try and avoid an infection if at all possible. Typically, we worry about an infection of your throat. So what we're really worried about is bleeding after this operation. So if you have an infection of your throat, of the area, the raw area where the tonsils were removed, if that gets infected, it hurts a lot more. And then suddenly you'll get bleeding, not just a little bit of bleeding, a lot of bleeding. And if you see a lot of bleeding, you have to go straight into an ambulance or get to your closest A&E department with ENT as quickly as possible and get that treated. Typically, well, let me go back a step. If you will see some bleeding after an operation, and typically, I think I did a little bit of research on this in a department which had a 1% bleed rate, or really good bleed rate. We found 33% of children out of these 100 people that we called up had some bleeding. They spat out a glob of blood a few days later and go, "What's that?" I said, "Well, I don't know. What do we do?" And then nothing else happened. Sometimes people bled and bled and bled, ended up going to A&E, and by the time they got to A&E, they were told, "You stop bleeding. I can't see any bleeding now. You might as well go home." So there is a range of bleeding, and you will see some bleeding. What I'm really talking about when I'm talking about really severe bleeding is that it's dripping and filling up a mug or something like that. Or it's quite hard to tell when you're spitting it out because a lot of it is saliva. But if you're worried, go to hospital because, I mean, I'm guessing most of the people watching this are adults. If you and I lost a pint of blood, so what? We donate that, when you're giving blood. But if a child, say this height, loses a pint of blood, that's a significant proportion of their circulating volume. And we're really worried that that's going to be catastrophic. That losing half your blood is terrible, obviously. But losing 5%, 10% for an adult is not so bad. So if you're worried, go to hospital, and it's the safest place. Typically, when you get to hospital, the bleeding's stopped, and there's a lot of sort of boredom as you wait around in A&E. And even if they are bleeding a little bit, a lot of people seem to ignore you, and that's just modern healthcare, I guess. If we had the resources, we'd treat everyone like a prince or a princess. But we have to focus our efforts on the really severe people, and the vast majority of people coming in with a tonsil bleed, where we just say, "Oh, it's not bleeding anymore. There's a little clot," or even there isn't a clot. But just to be safe, we often keep children in overnight and say, "Look, don't eat or drink tonight. We'll give you some fluid via a vein here so you don't feel so thirsty. And if you start bleeding in the middle of the night, we'll take you back to theatre." If you're still bleeding when you come to A&E, you'll go typically straight to theatre and have someone cauterize that bleeding spot. And also sometimes give you a transfusion of someone else's blood. That you've lost a lot of blood at that stage. So there is a little bit of a worry there. So the main problem after this operation is bleeding. but we're really looking for a lot of bleeding. But if you're worried, go to A&E and just get it checked out. Now, a lot of people are particularly worried about pain after the operation, and you might find the first day or so not that painful. And then it sort of ramps up a little bit. Day 3 is typically the day where most people have a lot more pain. Um, and it goes on for about till day 5, 6 or so, and then starts calming down again. Sometimes, as it's calming down, you get what's known as a secondary infection. You can get an infection of that area, and the pain goes back up again. And that's slightly worrying. And we go, oh, so you get an infection. There's a chance of bleeding with infection. That's typically why these children bleed. So if you're in that situation where first 1 or 2 days were okay, manageable, then the pain got worse, and then started getting better again, day 5, day 6, but then suddenly the pain started getting worse again. It's this sort of roller coaster. And you think, oh, this is really bad. Make sure you're taking those painkillers regularly. Make sure the child is eating, and be very vigilant about bleeding. Because if your child starts bleeding, get ready and take them to hospital. Uh, Giving antibiotics at that stage might be a good idea if you can see someone, a GP. Most ENT hospitals have what's known as a casualty clinic or a hot clinic or something like that, where you can call up and say, mostly through your GP, and say, I'm worried about my child. Can I, instead of going to A&E and waiting God knows how many hours there, can I see the ENT guy or one of the junior doctors in the hot clinic or the casualty clinic to take the burden off A&E? And then you can see one of the doctors in the ENT department and go, he's not eating as much as before. His pain's getting worse. I'm really worried. Can you just have a look, or something like that? And that's available in almost every single ENT department in the country. So try and use that service if you possibly can. Some services are a bit overfull, and they may say, look, unfortunately, you have to go to A&E. But that is a service out there for people. You can typically see them within 1 or 2 days. If your child gets a temperature afterwards, now there is a little bit of temperature in the first day. Nearly after every operation, everyone has a slight temperature. But if you're talking about a really high temperature afterwards, the sore throat's getting worse, very likely to have an infection. Get seen by your GP, get some antibiotics, come to secondary care, A&E, or the casualty clinic in ENT. They'll give you antibiotics as well. But the main thing is if your child is managing to eat and drink, we would rather you be at home, because in hospital, you're more likely to pick up a bug from one of the other patients, or from all the infections running around in hospital. But if you're able to eat and drink, we can typically get you home. So if you were to come in and go, look, he's not eating and drinking, but you haven't tried paracetamol and the Nurofen, you haven't tried all these other things, all we're going to do in hospital is give you painkillers and keep waiting until they can eat and drink. But if you're really struggling, I'm not saying don't come into hospital. If you're really struggling, come into hospital and look after them. But there's no special sort of source that we have in hospital that you can't get at home. It's painkillers and just looking after and just keeping you in a place of safety. At some point, your child will be starting to eat and drink again normally, and you can start reintroducing the foods that before you probably wouldn't choose, like pineapple juice and orange juice, because they're quite acidic. It might hurt a red raw area at the back of your throat. If you're a family, like Indian family like I have, we have lots of spicy food. That's probably not the best thing straight after an operation with sort of red raw areas. But as time goes on, typically sort of day 7, 8, or 9, when things are a lot better, you might say, well, let's try and introduce these foods again. And after 2 weeks, 10 days to 2 weeks, you can get your child back to school and just let the school nurse know that he's had an operation. He's going to be a little bit weaker than before, and they'll be a little bit more tired, because this happens for the first 6 weeks or so. It's called a catabolic state. After you're having an operation, particularly one as big as the tonsils and adenoids, you get the body tries to get protein from the rest of your body. So it harvests protein from your muscles and uses that protein to try and repair the damage in your throat. And so for the 6 weeks after an operation, your body puts a lot of effort into trying and healing this as quickly as possible. I mean, it's a hangover from evolution. Say we were some sort of lion, or some mammal or something like that needs to hunt or gather for food and things like that. it's not designed for social creatures, but if you're injured for whatever reason, if your leg got hurt by an attack by some predator, and you're just lying on the grass somewhere, this is as a mammal, um, your body goes, well, we've got to heal this. It doesn't matter how much of our resources we use to heal this. We've got to heal this so you can go out and get some food, because starvation was the thing that affected us most in our life. So that's why when we have an injury, we use up all our resources to sort of avoid that problem and heal this injury as quickly as possible. We're not really designed for people to care for us. We're designed to like just survive on our own on 2 feet if possible. So it's not really necessary in modern society, but it's a thing that we have. So you might find that your child is a little bit more, not listless, but a little bit weaker and a little less able to play football as much as he used to be able to do. And they may be more tired going to bed. That's normal. And over the next 6 weeks, that will slowly get better and better and better. So don't worry about that so much. And just keep going. And after 2 weeks, most parents have said, oh, everything's much better now. And he's gone back to school. Yeah, he's a little bit tired. He sleeps a bit longer. He's not quite as active and not bouncing around the house quite as much. The good news is that typically they stop snoring. They stop being a little bit more, they become less irritable during the day, less hyperactive. Children who eat very slowly and don't eat very much or very picky with their food suddenly start gobbling food down. You'll need to spend more money, unfortunately, on your children because particularly if they've had obstructive sleep apnea or lots of infections in the past, you may find that they'll suddenly start growing very quickly after these operations because the sleep apnea is not retarding their growth. The infections isn't using up all their resources by their immune system to try and fight this infection all the time. So they start growing a few months later and they seem to do an awful lot better. They do better at school, typically, if they're not tired, they're not struggling with breathing at night and all those things. We find that even children who are just simple snorers seem to do better. They have better school performance afterwards. Their educational potential becomes higher. So all of these things you'll notice after these operations, particularly if you've done the tonsillectomy for the right reasons. I should mention adenoids a little bit. If you've had adenoids out, the Great Ormond Street technique is to use monopolar suction diathermy, which is basically sort of not vaporizing, but sort of cauterizing and sucking off the tissue afterwards. We don't tend to cut it right off anymore because there's a high chance of bleed and a high chance of regrowth. But whatever technique they used, it tends to be a reduction of the adenoids rather than a complete removal. It's really hard to complete remove because it's attached to the back wall of the spine, the front wall of the spine. And the problem with that is that you leave a sort of sloughy area on the back of the nose and the sort of area at the back of your nose. And the only real problem with that is it's a bit sore in that area. And what can happen is it smells quite bad afterwards. You get like a dog breath for the first sort of 5-6 days. And so with the Great Ormond Street techniques, they typically say give amoxicillin or some sort of penicillin for the first few days, just to try and reduce that sort of smell at the back of the nose. So there's another reason not to go and play dates and just think, oh, God, what is that smell? That's very normal. So try and be mindful of that and take the antibiotics if you've been given them. Some people ask me about why don't we give antibiotics to everyone? If the risk of infection causing a bleed, give antibiotics to everyone. It doesn't really, unfortunately, change the chance of getting the infection. And so the other problem is if it doesn't change the number of infections you get by giving everyone antibiotics straight after an operation, then when they do get an infection, you're saying, oh, we've given them antibiotics for a week. They've got an infection now. What antibiotic do we give now? And antibiotics have their own risks. So the consensus right now is to not give antibiotics unless they need them. What else do people say? Hopefully that was useful. Actually, I should have mentioned this. I've got a book on tonsillectomy because I know, as a parent, it's hard to work out whether or not to do this operation or not, and how to look after your child afterwards. It's mostly for adults, but there's stuff about children in this book as well. I think it's 160 pages worth, so I really went down on a number of words on that. But it gives you all the information, I think. This is just a brief outline of what I talk about in this book. So hopefully you might find that useful. If you want it, there's a link in the video description below. And I hope you found that useful. I'm sorry, it's a really long video. There's a lot to say, I guess, as you can tell. Thanks for watching this. You take care. Bye bye.